particularly at the grassroots level, how devolution has fared and, of course, why that was necessary in the first place. And at the same time, we're going to take a look at some of the modern challenges with the pay of doctors, some of the challenges county governments are facing, and at the same time, the elephant in the room, the coronavirus and the impending fourth wave of the coronavirus that has been predicted by the medical experts. So thank you so much for making time to join us this morning, Governor Ongwae.
Thank you very much, Trix, and the entire KTN News team.
Okay, so let's start off with we just celebrated Madaraka Day, and of course this is the time to reflect on the gains that we have made and perhaps some of the shortcomings that we have in terms of development, and health is a big sector that needs to be looked at critically. So when you look at the journey that the country has made, what would be your rating, and how would you say we have done so far?
Thank you very much. First, let me thank the entire KTN team, especially on the informative nature of your discussions with those leaders that you call here. For us, for me particularly, and for a number of us and all of us governors, when we started devolution, some of us identified health services as a critical area that we needed to give adequate funding. And when we came in, most of us, like I'll give the example of Kisii County, we had serious problems in the area of human resources, in the area of infrastructure, and broadly speaking, in the area of the determination between primary health care and clinical services. So what most governors did was that we prioritized health, and almost more than half, 3/4 of the counties actually are spending more than 30% of their budget on health services. In Kisii County, I think I spend around 45% on health services. What we did find, if you looked at the area of staffing, you would find that we didn't have enough doctors. If we had a few doctors, we probably didn't have any specialist doctors. And allow me probably to keep on using the example of Kisii County.
Okay.
When I went in, there were only about 17 doctors, and we didn't have any specialists. There were 2 specialists, but they were all in charge as administrators of the hospital. We now have about 177 doctors. And we have a huge number of specialists. We have almost about between 40 and 50 specialists. I also have 67 officers that the county government has actually approved, 67 doctors that are undergoing master's training in various areas of medical specialization. And that can be replicated in quite a number of other counties.
Right. Now, okay, go ahead.
Yeah, in the paramedical area, whether you're talking about clinical officers or nurses and other staff, these numbers are almost doubled in all the counties. That is in the area of human resources. In the area of equipment, or rather health infrastructure, if we start with equipment, then we'll go to the structures, the buildings, and so on. I would look at it in 3 dimensions. First, if you look at diagnostic equipment, you would find that most counties didn't even have CT scans. Most counties didn't even have MRIs. And we now have, in Kisii County, we have CT scans, not even the basic ones, but the 64-slide CT scan, probably one of the best, with the best resolutions. We have MRIs that can be able to look at your entire body. Under the lab equipment, we have biomedical equipment in most of our counties. In Kisii County, we have biomedical analysis machines. We now have a PCR machine which has just been installed.
Right.
Under critical care, most counties actually didn't have ICUs. They didn't even have HDUs. They didn't even have the latest type of theater machines. We now, in Kisii County, we have ICU, we have HDU, we have some of the best theater machines, and that can be replicated in nearly all the counties.
Okay. Now, when we're having this conversation at a time also when we are looking back and of course projecting forward, and to project forward we have to accept that there are some shortfalls. We're not there yet, it's not perfect. So what are the things that you see when it comes to the devolution of health services that you wish could be streamlined to ensure that things are faring on better?
I think first you must start with the budget for health services.
Okay.
The budget for health services needs to be increased. Granted that we have given big portions of our budgets to health services, like I did indicate to you in Kisii County, is between 45 and 50% of my budget.
Yes.
But what does that mean? That means that one crowds out roads, one crowds out agriculture, one crowds out urban development, one crowds out the education, the lower level education that is devolved. Basically, one crowds out everything else, including all other issues that relate to operations and maintenance.
Right.
So we need, and that is why the new constitution that we are fighting for would actually have helped the counties, will really help the counties, because with the increase of resources, it would be much more easier to give more resources to the counties. The second issue that I wanted to mention is that the national government retains quite a lot of resources under health. I think we probably take about 10 or 15% of the resources for health to the counties, to all the 47 counties, and about 80 to 85% of the resources remain in national government. This is a conversation that our national parliament needs to look at. Both the Senate and the National Assembly, they need to look at that, so that funds are actually distributed to the counties in order for us to improve health services. So budget is one area.
Right.
The second area is on staffing. We need to look at increased staffing so that both for the doctors and for the nurses and for the clinical officers and for the other 17 paramedical specializations, so that we are able to meet the WHO requirements on health coverage.
Yes.
So that our people can get proper health care. The third issue that one would look at is the distinction between primary health care and the curative services.
Right. Yeah.
We are spending too much money on curative services, which means that we have a general assumption that we are going to be sick, and therefore we give probably, and this happens in national government and even in counties,
right,
where you are actually giving about 70 or 80% of your budget on health services to curative services, and probably giving about 20% to primary health care and general public health, while it should actually be the other way around, where you are stopping people from being sick. Now,
I'd like you to just dig deeper into that element of primary health care, which is very important. And when you look at the Big Four agenda, it's also part and parcel of the blueprint. So what are some of the things as a governor that you see at the local county level that you know for sure, if we had primary health care that was well set up, we would not be experiencing that? Far from the funds, of course, if we had that scenario that you're pointing out that is in reverse, what would we have been seeing in terms of it? Let's talk about actual illnesses such as malaria or maternal health care.
When you're looking at primary health care, and it's nice you brought in the whole issue of UHC and tying it up to the reforms that should be undertaken to NHIF being the primary insurance cover for government. UHC, and broadly speaking, the Big Four agenda for our president is extremely important in this country, and is probably the cornerstone for the primary health care program that should be rolled out in this country. And if indeed we were to succeed in health services, then we would give more resources to primary health care and to the UHC program, where you are looking at first, let's look at before people become sick, because after they become sick, then you start dealing with the national store insurance, with NHIF, and whatever covers the insurance covers that you're talking about. At the primary healthcare level, you are looking at what we call the volunteers.
Right.
We have volunteers at the local level. That is under the units that we have, level 1, level 2. You have the public health volunteers at that level. If we would have enough resources, have those people at the local level, because the role of those people at the local level is really to work with the communities.
Yes.
And empower the communities to understand broad public health issues, whether you are talking about availability of toilets, whether you are talking about clean water, whether you are talking about broadly ensuring that we are able to control malaria. You know, they go to communities, and if they find that malaria is actually increasing, then they try to look around to see if there are any ponds around that would be harboring the mosquitoes and so on. So the community health volunteers then become our frontier of ensuring that we are able to stop our people from getting into the hospitals. The issue of cleanliness at the local level, those simple issues that are taken for granted come to haunt us later on, because then you can get waterborne diseases, you can get malaria, you can get very, very serious diseases at a later level. So I think I would want to say that at that particular level, at the community level, if we are able to improve on level 1 and level 2 and level 3 of our hospitals, we would be able to arrest to ensure that primary health care is picking up. On the general assumption that, okay, one gets sick, then you start looking at our insurance cover that we have in this country, which you know that the policy is actually not clear. We've been grappling with the National Store Insurance Fund for a long time. I do know that we have amendments that are going on about NHIF and the coverage modalities at the local level. But at the moment, we have a serious problem in this country, because I think the coverage level could be extremely low. I suspect probably about 20% or thereabouts. You want to increase that, and that is the cornerstone of the UHC program of the President under the Big Four agenda, where the determination of the indigents at the local level, those who can't basically afford health services, is ongoing at the moment.
Okay.
The Council of Governors, the Ministry of Health and the Council of Governors have had broad discussions. A checklist was given to the counties where we have determined, all of us, the indigents. That is the indigents, that is the households that cannot afford health services and need to be supported. If I give you an example of my own county,
yes,
we were able to identify about 150,000 households out of the 350,000 households we have, which is almost close to half, slightly less than half.
Okay. Now, if all this is streamlined and what you're hoping, what you would like to see, more funds directed to, you know, universal health care and primary health care, health cover and primary health care, then we would have less monies. Let's say your 50% might go down to 20% when it comes to how much you're spending on health care. Is that the assumption? That would be the assumption, because if people are not sick, it means they'll not go to hospitals. Yeah. That's basically what it means. Yes. And that is the cornerstone of even the COVID-19 that we have here, where you are telling people to mask, where you're telling people to wash, where you're telling people to keep distance. Why are you actually doing so? Yeah,
You are
because
doing so so that they don't become sick, so that they don't get into your hospitals.
right.
Yeah.
Now, also, you've talked about the collaboration between the Council of Governors and the Ministry of Health. Now, it brings to mind, also, you talked about the issue you brought up about budgets. Now, when sometimes not really sometimes, but a lot of the time, we hear a back and forth between the governors, the counties, and the national government in terms of delayed funds, and therefore this leads to delayed bills. And of course, when it comes to health services, if you're having bills that have not been paid, then everything else is just delayed. So what would you say the experience has been, and are there systems that are being put in place to ensure that this comes to an end?
The experience has actually been, if I can use a bad term, has been completely horrifying because, for instance, we've not received our funds. We are behind by 3 months.
Wow.
For Kisii County, 3 months means 2 billion shillings. So if, and we are now coming to the end of the financial year. Now, for my mother at home, she doesn't understand that. All she knows is that there is the devolution program.
Right.
She knows that we have resources for running health services, for running many other things at the local level. So to start to explain to her that we have not received funds for 3 months won't make sense. Now, what that means that if I have not received funds for 3 months, it means that whatever payments that I was going to make, whether it is for drugs, whether it's paying contractors who are putting up an health facility, whether it was for buying equipment, it means that you actually cannot be able to do that. And this is a matter that we have discussed even at summit that is normally attended by His Excellency the President and the Cabinet Secretaries. We have brought up this matter. We have also gone to Parliament. We have had a meeting with the Senate on the issue. We have discussed this matter at all levels. The last time we also even went to the National Assembly. This is a matter that I think the Fourth Estate, you also need to come up. You've been a bit too kind to Treasury and to national government in general.
Okay.
Because the counties are suffering. When an analysis is being done about service delivery, of course it is indicated that service delivery is poor, but nobody goes behind to find out the reasons for that poor service delivery. It's easy to stigmatize, it's easy to say poor service delivery, without actually going behind to find out why are we having poor service delivery.
Oh, and by stigmatize, you mean pointing an accusing finger at governors such as yourself, as opposed to the chain of events that leads to poor services?
Yeah, you've seen it. I've been a governor now for 9 years, and that stigmatization has been going on. But the governors really are suffering because we write letters, we follow this issue, and we are now coming to the end of the financial year. We've not received funds for 3 months. So some of us have got into arrangements where we are even paying salaries through loans from banks and so on. So we would want this matter brought out clearly. We would want our leaders in Parliament, because the onus actually falls on them to ensure that county governments also receive their monies like national government receives. National government ministries receive their money every month. Right.
And now I'm looking at a data set here, a representation of county government's own source revenue categories of 2016 and 2017. And it seems to imply that 11% of revenue comes from health services. That's actually 11%. That is quite a bit. Isn't this enough to actually be pumped back into the county government health facilities and systems? Or am I reading this data wrong? How does it work? Is there enough generated from local health services to actually keep the boat afloat?
Now, let's take the period under the pandemic, the last 1.5 years.
Yes.
And remember that whatever resources that the county that is being generated under health services is under cost sharing measures, which means that it is not like what you would pay in a private hospital. It is basically monies that people are paying just to keep the facility going. There is there is no other motivation behind it.
Ah.
So what happens is that whatever resources that come in, they are only help for operations and maintenance of those facilities. They would not actually help you to even buy drugs and other medicines. They would not help you if you wanted, for instance, to buy some diagnostic equipment. They wouldn't help you do that. So it's a broader question. Own source revenue in health services, it's a difficult thing. It's a very, very difficult thing because if you ask me, ideally under normal circumstances, nobody should pay for health services.
Yeah.
Yeah. But otherwise, you start looking for money. When we are looking at communities, I've told you we have about 350,000 communities in Kisii, and the indigents out of that are almost over 150,000 communities. Those who can't afford.
Right.
Now, if they completely can't afford, you find that probably those communities are the ones that live under conditions that lead to diseases, and therefore are bound to get to hospital much more than other communities who probably can afford slightly better life. What are you actually asking? Are you asking this indigent community to come and pay for the facility to run when you should actually be giving them free health care?
Yes, yes.
What are you saying? And that is why we are seriously pushing for reforms in NHIF so that we can be able to offer free health services to our community, because we all appreciate the fact that a healthy nation is a nation that could actually lead to serious development.
Right, and that is quite the conundrum. And we'll be remiss if we ignored that. We only talk about the services being rendered to the people and the service providers, who are very key, especially right now that we are in a pandemic. The last time we had you, I do believe, having an interview around on this premise, it was with our sister station Spice FM, and that was a time when doctors were threatening a strike at a very, very critical point in time where they were needed, but then they felt they were not being remunerated right. And your stance was that it should never happen, that they should not be going on strike. So could you walk back to that point in time, the challenges that medics were facing? And you have pointed out that more have been hired under devolution in terms of healthcare. And what is the situation right now? Has there been changes? Are there plans by the Council of Governors to ensure that things are better for those who are providing these critical services?
Thank you very much, Ma'am. I would want to tell you that when we started devolution 9 years ago, I became the chair of labor and human resources in the Council of Governors.
Yes.
And therefore was completely central to discussions that related to welfare, that related to salaries and benefits and so on. And we got into discussions with the health personnel. In some time back, I think it was in 2016 or 2017, you do recall that the health workers went on strike for 5 months.
Yes.
The end result of that was that we were able to improve salaries tremendously. For instance, doctors now at the lowest level earn about 250,000 shillings at the lowest level. At the highest level, you would be dealing with over 300,000 shillings. Nurses are earning over 80,000, 70 to 80,000 shillings. Clinical officers the same. And this is out of the increases that we agreed with them, that we agreed as government with them, notwithstanding the fact that we also have other cadres.
Yeah.
We have engineers, we have architects, and I will tell you, and it's unfortunate I have to say it on national TV, but these other cadres probably earn much, much less than probably even the nurses and others. But granted, be that as it may, we have improved their terms and conditions tremendously in the context of our ability to pay,
right.
Because pay is based on the ability to pay by the organization. Like in this organization, whatever you people are being paid as salary is based on what this organization can be able to pay.
Right.
So government has tried its best. We have ring-fenced health staff. They earn much, much higher than the other cadres in government. We have close to 1,000 cadres in government, but health staff are actually ring-fenced. Their salary is much, much higher, and we are not complaining. Yeah.
Okay. Okay. So now moving forward, if we are to hope for a better health systems, let's talk about the projection that has been made by experts that Nyanza is going to be the new epicenter of the coronavirus. And of course, you've talked about the challenges, and we do know, for example, there's an article here in page 11 of the Standard that tells us that most hospitals lack ward space for admission, forcing some patients to lie on the floor. This is in Nyanza region, where hospitals and mortuaries are strained because of the increasing numbers of the coronavirus infections. How do you foresee county governments faring under a possible fourth wave?
Now, let me start first with the measures that were put in place. During our summit, our last summit meeting with the president, as county governments, we all agreed that we are going to have a minimum 310 beds.
Yes.
For COVID-19. We also agreed that we are going to put in place ICU equipment, mainly for oxygenation. And I think that was done in all the counties.
Yes, but at that time, the epicenter was in Nairobi.
Yeah, the epicenter was in Nairobi, but
yes.
It was generally agreed that in the broader context of preparedness, that each county needed to have 310 as a starting point. And that's where I'm starting from.
Okay.
And that counties were able to put that in place. But now, what did happen is that for a long time during the first and second wave, actually those 310 beds were not being utilized, especially in the Lake Region counties, those ones that are fronting the Lake Region.
Yes.
It is a problem that they are confronted with. It is a problem that developed countries were not able to handle. Remember that the US had a similar problem. Remember that India has had a similar problem. So it is a problem that you can't relate to the management of health services in the counties, because nobody would be able to have determined how many cases were going to come in.
Yes, yes, yes.
But our discussions in the Lake Region, we have agreed that we share resources. We have agreed that those who have facilities support the others. I am not so sure that the situation has completely got out of hand. The last discussions I had with the governor of Kisumu was that they were really trying, especially on the outlying facilities,
yes.
moving the support from not only from the main urban center, like in Kisumu County, from Kisumu Teaching and Referral Hospital to the outlying facilities.
Yeah.
In Kisii County, I have 300. I had 310. I added another, I think, another 30.
Okay.
So my about 200, and we have actually not utilized for the time being about 260 beds. They have not been utilized because we've tried to keep, we're fighting to ensure that the disease doesn't spread very much.
Okay.
We have been utilizing about 70 beds. Out of those, we have ICU facilities. We have about, I think, about 15 ICU facilities. We also have our own oxygenation plant.
Okay.
We have our own plant in Kisii. So we do not have a problem of oxygen.
Okay, and you have been lauded for the work that you have done in Kisii County as far as health is concerned by even CS Mutahi Kagwe. So when having the experience and seeing the challenges and of course the possibilities that you can do even with the limited funds, what do you think other counties should emulate? There are certain problems that I do believe you agree are avoidable. For example, the overcrowding that we saw on Madaraka Day, that was something that could have been avoided if we were talking about coronavirus. So how would you advise, or how would you say, what are some of the things that other counties can copy from Kisii County if they're hoping to keep everything in check and of course fight the coronavirus?
Thank you very much, ma'am. First, let's start with life. I am starting to think that life must go on, because I wish we knew when this virus is going to end. And so, when we started, of course, we talked about masking, we talked about distancing, and we formed in the counties. We formed the COVID-19 emergency response committees, where national government officers, that is the county commissioners, and the police formations, who are working with our county enforcement officers and others to ensure that all these measures are put in place. But human beings all over the world have this habit of, after a certain time, again, retrogressing. I think that has been going on, not only for, I think it's been going on in this country and in our counties. But again, it's not only in this country, it is all over the world,
yes,
where you're seeing a retrogressing, general assumption that this thing is here to stay with us, and people sort of taking certain things for granted. I think this is what we, as a Council of Governors, we keep on telling each other, and we're working closely with the national government to ensure that we work on masking, we work on distancing, and so on. It is a problem. It is an issue that relates to human beings. It's an issue of